So
You're not going to show up, sir.
I'm going to start now. I was waiting for Dr. Eddie, but I have a lot to talk about. So for those of you who don't know me, I'm Eliezer Soto. I'm a former fellow. I'm still a fellow, but I'm doing research now, not the clinical work. And Dr. Eddie asked me to come here. I'm trained in palliative care. I did that 2 years ago, and I trained in interventional pain last year. If I get tired of being here, I'll stand up. I cannot be in one place for more than 5 minutes. All right. As we all know, the definition of pain in general is a very old definition. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And it's very interesting that we include sensory and emotional in the same definition. That we'll discuss a little bit later. This is data is a little bit old, but over 30 million Americans suffer from chronic non-malignant pain. Acute and chronic pain are serious problems for up to 30% of the U.S. population. The hospitalized patients, like 50% of them complain of pain. And the AIDS population, not HIV positive AIDS, they complain the pain is inadequately treated in 84%. And this last point here, 73% of advanced cancer patients admitted for palliative care receive inadequate pain relief. This is more data from oncology a while back, not the palliative care currently. Prevalence of cancer pain and time of diagnosis, 30%. It keeps increasing. We treat and the disease gets progressing. During active treatment, 30 to 50% and 70 to 90% with advanced disease. 40% of our chronic pain patients, and we see that in clinic all the time, I would say even more in our clinic, describe that the pain is out of control. In the general population, 70% avoid calling the doctor when they're in pain, or they don't use the medication until the pain gets very bad or is unbearable. What is going on with the patient, with us, and with the system? Why are we not getting effective pain management? From the patient standpoint, most of them are reluctant to take medication or report the pain to their physicians. They lack of education regarding how to take the medication, when to take it. Some of the patients that I saw last year, they were taking long-term opioids as a breakthrough. I mean, you really have to educate them, especially if they don't have a good, high education level. So in terms of us, what is going on? There's inadequate training in pain management. Again, this data is a little bit old, but 52% of oncologists, they consider themselves their training in pain management was poor, or we're not making an appropriate assessment of pain. So that's what we're going to discuss today. There's a concern about tolerance, addiction, fear of addiction from our part, from the patient's part as well. And the side effects sometimes are not tolerable for the patients. In terms of the healthcare system, I would say the first point here, low priority given to pain treatment. I think that has been changing a lot, especially in the inpatient setting. Inadequate reimbursement, restrictive regulation of controlled substances. That's getting worse and worse as we speak. Problems with availability of or access to treatment. That's also a big problem. For patients in Medicaid patients in our clinic, sometimes they have to wait 4 or 5 months to get a first appointment with us. So, in terms of mechanisms of pain, and we probably know this already, we have nociceptive pain that is divided on two, somatic and visceral. The somatic is the bone type of pain, aching, more localized. The visceral is more vague, aching type of pain. We have neuropathic pain that is more, the patient describes it as more shooting pain, burning, and there's also a type that I didn't include here that is the mixed type. It's a combination of everything. Okay, this slide is a little bit overwhelming, but that's how we feel in the first week of fellowship when we start seeing our patients, either palliative or pain. It's not only what is the mechanism of the pain. This is bone pain. This is, in general, cancer pain, neuropathic pain, but it also, is the patient working, not working? This was an injury related to the job. How is the patient emotionally, spiritually, the social support that the patient has, any financial concerns, is the patient end of life, or this was a recent diagnosis. A lot of things that we have to include in our initial assessment. And sometimes we have half an hour to do all this. Sometimes we have to see the patient back and complete the evaluation. It's a lot in one session. So in order to do this more efficiently, we have to do it more systematically. We can start with pain history of past medical conditions that are relevant to the current problem, psychiatric comorbidities, psychosocial factors, risk of addiction, assessment of function, goals of treatment, physical exam, diagnostic modalities, and follow-up visit. I'm going to go through all this. Follow-up visit is pretty much going through everything again. In the pain history, it's important to know the extent of the disease, regardless if it's cancer, what type of treatment the patient had, if it's HIV, any opportunistic infections, if it's a patient with spinal stenosis, how bad the condition is. Regardless, if we're seeing a patient in a palliative setting or just chronic pain setting, we all have to know this. Any signs and symptoms that they had from previous therapies like chemotherapy or radiation, other medical conditions, and we're going to be doing procedures or prescribing medications, so we want to know the kidney function, we want to know the liver function before starting any other treatment or doing any other modalities. And also how effective or not effective were previous therapy. Common cancer pain syndromes that we have to be aware of. The pain could be as a result of the tumor. It could be as a result of a treatment, chemotherapy, radiation, or even surgery, or non-malignant pain. In terms of the tumor-related pain, it could be from metastasis, as we know. It could be meningeal involvement, spinal cord compression, different plexopathies from breast cancer, brachial plexopathy, peripheral neuropathy as well. As a result of a treatment, mucositis from oral radiation in the oral mucosa. And non-malignant pain, and that was my experience as well. Sometimes we have a patient with cancer and they have pain, and all what we think is, this is cancer related. It could be anything. And that's why it's important to make the appropriate assessment. You can have a patient with Hodgkin's lymphoma and high-dose steroids and have avascular necrosis of the hip. And that's not related to cancer directly. Related is an effect of the treatment. Pretty much we're causing that. So I like this algorithm, to put it like that. It's more systematic. We can start with onset, OPQRST. Onset, provocative or palliative, that's what's make it better or worse. Q, quality of character of the pain. The region, the radiation, how severe, and the timing of the pain. And we're going to go through all this. In terms of onset, how or when did the pain start? If it's acute versus chronic. If this is a pain that started after surgery, after the first chemo session, is this neuropathy that is related to the chemotherapy. This pain that is well documented, that we can look at MRI and say this is an infiltration of the tumor in the lumbar region, or this is like some of our fibromyalgia patients that they have pain from head to toe, so we don't know exactly what is causing the pain. So it's very, very important to know when the pain starts. If it was also a result of as a result of an accident, or what was the cause, and how long ago, the chronicity. So what is acute pain by definition? Is the normal predicted physiological response to an adverse chemical, thermal, or mechanical stimulus, and it's associated with surgery, trauma, and acute illness, and is generally time limited, and is responsive to opioid therapy among other therapies. And chronic pain, on the other hand, is a state which is persistent and in which the cause of pain cannot be removed or otherwise treated. Chronic pain may be associated with a long-term, incurable, or intractable medical condition or disease. This is by definition. In terms of what makes the pain better or worse, it could be better with medication, or sometimes, like our patients say, the pain gets worse with medication, some of them say. Is it movement related? Is the patient, when the patient is standing or walking or eating, swallowing difficulties with patients with mucositis or dysphagia, weather changes in patients with osteoarthritis, or what time of the day, if it occurs more when they're waking up in the morning or during the day with activity. The quality of the pain, and this helps us a lot in terms of if it's a neuropathic versus somatic, nociceptive type of pain. Is the pain shooting, burning versus dull, like a soreness or pressure-like? These are very different descriptions. And some of the scales that we'll see later use all these adjectives to as a matter of like a questionnaire for the patients to know what type of pain they have. The region or radiation is very important to know the specific location, or if the pain is far from where the regional lesion is. That's we call refer pain. Not the same thing to to have an invasive tumor from in the ovaries versus having shoulder pain, but it's not related to any shoulder pathology. Will be from a liver pathology or gallbladder pathology is a refer pain. Same thing with groin pain. Could be refer pain from hip, necrosis of the hip, and hip pathology, or back pain from a pancreatic lesion. So we have to know, exactly where the lesion is, or this is a referral pain from another lesion. Severity. There are many scales to measure severity, and some of them are validated, others are not. The ones that we use more frequently are numeric rating scale, VAS, and verbal rating scale, and I will tell you the difference. And also McGill pain questionnaire, or the short version of that. The last four are for pediatric, and I'm sure Dr. Lerner is going to give you a lecture, or if she already did, on pediatric pain. The Ausher scale and FACES are self-report. The kid above the age of 3, they can tell you using these scales. For infants, neonates, you can use, for example, the last two, FLAC or NIPS. FLAC stands for face, leg, activity, cry, and consolability. And these are more observational, since they cannot report, what they feel. In terms of verbal rating scale, which is the first one that we have here, we use it all the time. The one that we use the most is this one, the numeric rating scale, even though we call it VAS, but it's not really VAS. When you ask the patient if the patient is mild, moderate, severe, the worst possible, that's VRS. When you ask the patient from 0 to 10, how bad your pain is, that's numeric rating scale. VAS would be similar, but it's just drawing a line, a 10-centimeter line, and the patient will make a mark, where the pain is, and then we measure from the origin to where the mark is. The one that is validated the most, or the one that we use in research most of the time, is VAS, and these two have limitations, since here we are assuming that the pain from here to here is the same interval than from here to here. So we cannot really follow that pattern. The pain doesn't go like that. And these are phases that we can use, in kids or in the elderly as well. McGill Pain Questionnaire measures subjective pain experience. There's a short form available, There are 78 adjectives organized in 20 sets. Some of them we mentioned before. 3 dimensions: sensory, discriminative, affective, motivational, and cognitive, evaluative. Each descriptor is assigned a score, and then you sum everything. Advantages is reliable, it was validated, it takes some time to use, but not as bad. And the concerns is limited to the patient experience of pain. But we use it a lot in research, for research purposes as well. Okay, this is what we call daily diaries. There are many versions of it. It's very useful when we sometimes we cannot get a report from the patient in our visit, and we have to give them this type of tool so they can take home, and they will tell us exactly when they had pain, what they took, what type of activity they were doing when they had the pain, how severe it was. We can add a lot of things to the daily diaries, and also now that I'm more involved in research, I can tell you that it works very well. It's not the same time to have one place in time and ask the patient how you're doing right now than to follow the patient for 2 or 3 weeks and see the variation, and we can get more information this way. And it's for research, and also the clinical practice works as well. Really like this picture. It's kind of intense, but that's how the patients feel. The timing of the pain, if it's neuropathic, it happens all of a sudden, or is a patient that you can predict. It's incidental, when the patient is moving, when the patient is walking, when he's getting out of bed, with a patient with osteoarthritis, for example. With headaches, this is extremely important when we're dealing with headaches. If it's a headache that is all the time, wakes the patient in the middle of the night, related to a brain tumor, or it is more a tension headache that happens with stress, or it is migraine headache with aura. So the timing of the headache, and how many times a day, how many episodes per month, this is extremely important to make an accurate diagnosis. Also, baseline pain versus breakthrough pain. I would say, I don't know the percentage, but most of the patients have 2 different types of pain. One that is there all the time, and then when they do something, it gets worse. So we have to make a distinction and to see which medication works better for each episode. In terms of ongoing pain assessment, it's very important for us to have regular visits with the patient. Any new report of pain, take it very seriously, especially in the cancer patient population. Patient that is stable on chemotherapy, all of a sudden there's an increase in dosage or more tolerance. This tells us that there's something going on with the malignancy, with the tumor. It's also very important to make an assessment after you change the medication, after you change the therapy. Did it work? Didn't work? Any side effects that the patient had? And also, it's important to train the family and the patients to make an assessment at home. And the daily diaries, is very helpful for that. In terms of psychosocial examination, I'm not going to go in too much detail because I'm going to get a lot of lectures on this as well. But it's very, very important. And it was, I would say, 2 years ago when I was doing my palliative medicine fellowship, it was very hard for me to try to make a psychosocial evaluation at the same time asking the patient about the physical symptoms. For example, going from diarrhea, constipation, so, tell me more about how you're feeling emotionally. That transition was kind of hard if you don't know how to do it, how to flow during the interview. And so it takes time, practice, and a lot of effort to try to put everything in your head together. Very important to know what is the meaning of the pain. Some patients, if you take the pain away, they lose their identity. So they live with the pain, they cope with it, and if they don't have the pain, I would say a good percentage of chronic pain patients, they don't know what to do. They're not working. All their life revolves around the pain that they have. How they're coping, support system. Are they completely by themselves, or they have a good support system? Are they depressed? Is the depression related to pain or to something else? The concerns that they have about controlled substances, and we see this in our chronic pain clinic, patients that with prior history of substance abuse that don't want to take an opioid. They need an opioid. They need something stronger, and you are trying to convince them that they need that, but they don't want to take it because of the prior history of substance abuse. So it's very, very hard in this scenario when they need a medication, but you have to respect the decision because they don't want to go back to what they were. Any financial concerns regarding the therapy that they're receiving. Okay. When you can find many different types of patients, but recently diagnosed, two different types of patients. Recently diagnosed breast cancer, extremely highly functional woman, professional, educated. She comes to your clinic and she's ready to fight, whatever. She has pain, but she doesn't care. She's going to take whatever. Her self-esteem is extremely high. She wants to do everything to fight their condition, her condition and her pain, versus the patient. When you meet the patient in the first visit, is already emotionally destroyed. So you have to make the same assessment. But they are going to have different needs. But these are two out of many patient characteristics of patients that we see on a daily basis. In terms of psychosocial examination, I'm going to mention a few scales that we can use as well. This is the Minnesota Multiphasic Personality Inventory. It's extremely long. You have different versions. You can have 180, 370, or 566 true-false questions. And no one is going to do that in an hour consultation visit. But it's a tool that you can refer the patient to have with a psychologist, and you have to be aware of the tools that you have to measure this. It's validated, it's extremely long, and also needs a highly skilled evaluator, not only a patient with the patients to do this. The BAG Depression Inventory, like the word says, assesses the level of depression. It's a lot shorter, 21 items. Includes two subscales, somatic performance and cognitive affective. It's very easy to take. It has been around for a long time. No validity scales, and is very limited in scope. It's mostly for depression. Symptoms checklist, the 90R. It screens for psychological symptoms and overall distress level. 90 items. Yields 3 global distress scores measuring current depth of pain disorder, intensity of symptoms, number of patients reported symptoms. It takes like 15 minutes. Yields an overall measure of psychological distress. Can be used as screening, but cannot be used as a diagnostic tool. In terms of risk of addiction, I'm not sure why don't we use this type of scales here in our clinic, but two that I've used during my training are the SOAP and COMM. The first one is to help determine how much monitoring a patient on long-term opioid therapy might require. It's only 14 questions, 14 items. Score of 7 or higher, has a sensitivity of 91%. Of course, I was looking at the questions yesterday, and the patients can be extremely honest, or they can, put whatever they want. So it's very subjective, I would say. The second one is 17 items, score 9 or above, has a sensitivity of 77%. And if you're interested, there's a website called pain+assessment+physical+exam.org, and you can get trained with all these screening scales for addiction. Assessment of function. I'm going to mention two scales as well. OS3 Disability Questionnaire. This is mostly for patients with low back conditions. But you can assess activities of daily living, activity level. It's 10 multiple choice items covering 9 aspects of daily living. The advantage is easy to take. and correlates functional tests of impairment. On the other hand, there are not validity scales included in the questionnaire. Brief pain inventory that we use a lot as well. Measure pain related interference in 7 areas, like general activity, walking ability, normal work, relation with other people, sleep, enjoyment of life. It's an 11-point numeric scale, and it helps to demonstrate efficacy of pain medication in a variety of conditions. And you can use it as you're treating the patient and you're making progress or not. You can still use it in different types of the treatment. Pain Disability Index is very similar to BPI, 7 questions in the following domains: family, recreation, social activities, occupation, sexual behavior, self-care, and life support activities. Is 11-point scale as well, and the responses are all summed and you get a score. The last 2 are very similar. In terms of physical examination, I'm not going to go in too much detail because I know you guys get also a musculoskeletal exam from Dr. G and another neurologic exam from Dr. Portnoy, but I'm going to mention in general the points that what we have to look for. As we know, in physical examination and diagnosis studies, we have to know exactly what it hurts and try to avoid that site until the end of the exam, or where the patient is referred to. You should look at if the patient brings any imaging, look at that before to know exactly where the tumor is, what is invading, and then perform a good musculoskeletal and neurologic exams. And if you, at the end of the exam, if you need to order any labs, any radiologic studies, any EMGs, you should do that as well. In terms of general exam, we have to look at the patient since the first second when they get in the door. The general appearance, is the patient disheveled, is the patient well dressed, vital signs, the gait. Is this an abnormal gait, an algic gait, or abnormal gait? Is the patient using a walker, using a cane? Are they using it correctly? I had a patient once and she was wearing a brace for several months. I would say 6 months, and she didn't really need a brace, but no one told her to just take it off. So any evidence of tremor, muscle atrophy, mental status exam, which is could be part of the neurologic exam. You should consider it in some clinics. If they are above certain age, they just do it on everybody. You should definitely consider if you have any concerns of cognitive impairment. The site of pain. This is a focused musculoskeletal exam. Look for positional relief postures. The patient avoids the left knee because that's where the pain is. Patients that have seen this as well with permanent heat impact burn marks as a distraction sign. General posture, the patient with the head forward, the severe lordosis, kyphosis, alignment of the spine, shoulders, or pelvis. Again, look for symmetry, any deformities, muscle spasms, atrophy, scars, burn marks, leg length asymmetry. What you want to, after you observe, what you want to feel for, bony landmarks, any tenderness, swelling, crepitus in any of the joints or subcutaneous tissue, bogginess of the joint, muscle ligaments, trigger points in patients with myofascial pain syndromes. These are very important to feel as well. In terms of movement, moving like I'm sure Dr. Miranda does, every single joint in the body. Look for the muscle tone. Is it increase, decrease, any muscle weakness, and specific maneuvers like the Faber is flexion, abduction, and external rotation. You can use that maneuver for sacroiliac joint dysfunction. Other maneuvers, these are, we have tons of maneuvers. I just mentioned these. These are completely different one from the other. Sperling test is for the cervical spine with actual loading of the cervical spine while extending the neck, rotating the head, and if it's positive in the ipsilaterally, is with radicular symptoms. That's a sign of nerve root compression for abdominal stenosis. Valsalva with patients with increased intracranial pressure, or patients with a tumor or compression from a disc. Drop arm sign in patients with rotator cuff injury to check for serpus spinatus. The Faber that I just mentioned. Straight leg raise and radicular pathology, Kernig, and meningeal irritation as well. So there are many. I'm not going to go through all this because I'll be here for 2 hours. The neurologic exam, what to look for or ask about. Any signs, these are very important signs of sensory avoidance. Patients with allodynia that I'm going to define later, that are avoiding the clothes because it's extremely painful. Any skin lesions from, for example, varicella zoster, that tells you maybe the patient has shingles in the past and now having pain from that. Any ulcers in patients with neuropathy, either from diabetes or HIV neuropathy. Any swelling, again, patients with RSD, CRPS, we see this all the time. Any changes in color, it's things that we're going to look for in the neurologic exam. Okay, also patients with CRPS can present with sweating, loss of hair, thinning of the skin, changes from chronic peripheral neuropathy, loss of hair as well, evidence of autonomic dysfunction, involuntary movements, myoclonus. Myoclonus is very important in our setting because we're giving opioids to a lot of patients, and patients with kidney failure, they can have myoclonus. Any patient can have myoclonus, but if they are not metabolizing or excreting the metabolites, you can have more problems with myoclonus, which eventually could lead to seizures, although not necessarily. Okay, what you want to feel for, temperature differences. There are different tools actually that you can use to measure temperature, but since we don't have them available all the time, feel for edema, swelling, tenderness of the joint and soft tissue. Move to assess cranial nerves. I'm not going to go through that because we went to medical school, we know how to do that, but assessing the gait again, abnormal gait, ontologic gait, the balance, coordination, especially in the elderly or patients with neuropathy, finger to nose, heel to chin, Romberg test, the tone of those muscles. They're spastic, they're rigid, they don't have any tone, and this different neurologic condition, multiple sclerosis, upper or lower motor neurons. This is, I'm studying for my pain board, so this was actually kind of for me, but the important dermatomal levels and or nerve roots that we should know, we should correlate them with the muscles, right? Shoulder, as we all know, C5, elbow flexion, C5, C6, extension, C6, C7, wrist extension, C7, C6, C7, wrist flexion, C7, C8, finger flexion and extension, C8, and finger abduction, T1. This is also important to know, even if we are seeing only cancer patients, but we can pick up new lesions doing a good physical exam, not only assuming that the patient has cancer pain is related to cancer, but if he has a new pain, and the patient didn't have a neurologic deficit in any of these areas, it could be to a tumor compression in the spine. So that's very important. That means progression of the disease, and we have to pay attention to this as well. I understand that some of the patients that we see in the hospice setting we're not going to be doing all this because they're going to be in excruciating pain. But if we're in an outpatient practice, we have the time to do it, and there's a reason to do it. It's a good thing to have this in mind. Also, with the lower extremities, hip flexion L3-4, hip extension L4-5, knee flexion L5-S1, knee extension L3-4, ankle dorsiflexion L4-5, and ankle plantar flexion S1. Reflexes, and this is the last part. Also important, when you have hyperreflexia or you lose reflexes, C5, C6 for bicep and brachioradialis, C7 mostly for triceps, L4 for knee jerk, S1 for ankle jerk. Additional testing. I'm definitely not going into these details, but for patients with neuropathic pain, when we do light touch, vibration, pinprick, hit or call, we know more or less which fibers are involved. That's not going to make a lot of difference in the treatment, but for documentation, if the patient has increased sensation or decreased sensation, that is also important to document. These are important definitions that are included. Allodynia, pain from stimuli which are not normally painful. Dysesthesia, unpleasant, abnormal, evoked sensation, whether spontaneous or evoked. Paresthesias, these are abnormal sensations but not painful. Dysesthesias are painful. Hyperalgesia, increased response to a stimulus that is normally painful. Hyperesthesia, increased sensitivity to stimulation. And hyperpathia, a painful syndrome characterized by increased reaction to a stimulus, especially a repetitive stimulus. These are patients that you keep tapping, and as you tap or do pinprick or whatever, the pain gets worse. As well as an increased threshold. Okay, since you guys, the fellows, are taking the boards next year, October, I included a few questions here from the UNIPAC, the palliative care board review. Okay, do you wanna read the first one?
Effective pain management depends on comprehensive assessment of the cause of non-cancer related pain, cancer related pain, non-physical pain, all of the above.
Perfect. Very good. There are only 5. So. Dr. Lopez.
Pain described as shooting or stabbing, often result from damage to nerves,
Okay.
nerves, brain, viscera.
Mm-hmm. So which one? B? Then this one, this is from the palliative board review. And I kind of disagree. I think it's B and C. You can have centralized pain. I put it here for a reason. The patients with centralized pain can also describe a shooting, stabbing. So I don't think it was a fair question there. But it's B. All right. Whoever want to do the next one.
Visual analog scale. Well, it's probably all because it's minimally intrusive and measures intensity.
Yeah.
And the others.
Very good. Okay. A little bit tougher. Next. Dr. Miranda.
Which of the following limitations and activities of daily living, Spielberg state, trait, anxiety inventory, also street, low back pain, disability questionnaire, the back depression inventory, SL90 and MMPI, I think B.
Perfect. Good. And why? Well, it's the only one actually measures that. Activities of daily living, even though it's mostly for low back pain patients. But yeah, it's the only one out of all of them. The D is pretty much a symptoms, but are more psychological. It's just different. Depression, back depression inventory is just depression. The last one, MMPI, is more the psychological aspect or trace of the pain. And the first one is for anxiety. And the last one, anyone? Really more.
What is a symptom checklist? 90 and its revised version, SLR90R. Okay. I don't have to read all the options, right?
No. I think I gave you the answer on the previous one.
Okay.
But yeah, perfect. That's the only one. It's not 136 items. Is the only one that it doesn't describe the mood state, and it's not the most widely used personality test. It's the MMPI actually. Yeah, the last two questions I took from the pain boards, so they were tougher. All right, and that's it. Any questions?